Hello students, till now we have discussed about cardiovascular system symptoms. The symptoms which we discussed are chest pain, dyspnea, edema, palpitation and syncope. Now let us go ahead with the examination of cardiovascular system. First we'll discuss general physical examination. What are the things you see in a cardiovascular system examination? The first, whenever you see the patient, general appearance, how it will give a clue to some other diseases. For example, if the patient is bending forward, leaning forward, which we discussed in pericarditis. Okay, a pericardial pain, if it is there, he will bend forward and he will lean forward because that relieves the pain. Then, if the patient is having cor pulmonale because of emphysema, he may be having a pursed lip breathing. And after looking at his body stature, if the BMI is very less, that may give a clue that is cardiac cachexia, okay, because the BMI is less due to heart failure. Or if he is morbidly obese, that may be a risk factors for coronary artery disease. If the pulse rate is very less than 60 per minute, that may be a clue that he is suffering from some cardiac arrhythmias. Obstructive sleep apnea and sinus Stokes breathe, they are ominous risk factors and ominous signs in systolic heart failure. These are the things which you look from a general examination, general appearance. Now, what are the things you look in the patient by looking at his skin? Cyanosis. Central cyanosis is due to right to left shunt lesions like phallus tetralogy, VSD, ASD with reversal of shunts. Peripheral cyanosis may be due to the cardiogenic shock or peripheral arterial disease. Differential cyanosis you get in PDA with pulmonary hypertension. Cyanosis in the legs but not in the arm. Telangiectasias in the mouth, in the tongue and mucous membrane can be a clue to the Osler-Weber-Endo syndrome, where there is a right to left shunt within the lung producing cyanosis. There can be telangiectasias in scleroderma, then bronze color skin in hemochromatosis. Then xanthomas. There can be a skin xanthomas, tendon xanthomas and palmar crease xanthomas. The palmar xanthomas, crease xanthomas are very typical of type 3 hyperlipoproteinemias. There can be ecchymosis due to drugs, anticoagulants and platelet drugs, antiplatelet drugs. There can be petechial hemorrhages due to infective endocarditis or antiplatelet drugs. Then plucked cobblestone chicken appearance, okay, you get in pseudoxanthoma elasticum. Café spots, if it is there, that may be a clue that patient is having Leopard syndrome, Lamb syndrome or Carney's complex. You get in these syndromes multiple atrial myxomas, HOCM, aortic stenosis and ASD in Carney's complex. If there is a lupus peroneum erythema nodosum, that may be a clue that patient is having sarcoidosis. Erythromelalgia, you get in lymphangitis. These are the things which you see in skin. Now coming to the head and neck, what are the things you see in head and neck? First coming to the eyes. There can be exophthalmos due to thyrotoxicosis. There can be a ptosis due to the muscle dystrophies. Both can affect cardia, thyrotoxicosis and muscle dystrophies. There can be a lacrimal gland hypertrophy in sarcoidosis. Then sclera may be blue colored in osteogenesis imperfecta, which can produce AR and MR. Then there can be hypertelorism with the low set ears and micrognathia, which is a clue to congenital heart disease. Fundus examination, there can be raw spots because of infective endocarditis or retinal artery pulsations in aortic regurgitation. In the mouth, you see Hayes palate, Marfan syndrome can produce heart diseases. Large tongue can be a clue to amyloidosis, myxedema, Down syndrome. All three can be associated with heart disease. Orange tonsils you get in Tangiers disease, which can be associated with cardiovascular disease. Webbed neck you get in Noonan syndrome, Turner syndrome, and Down syndrome. Mitral phases in the face you get due to chronic severe mitral stenosis due to vasoconstriction and hyperemia of the cheeks. So these are the things which you see in head and neck. Now coming to the chest and abdomen. Patient may be having a barrel-shaped chest and kyphoscoliosis, which can produce carpal There can be pectus excavatum and carinatum, which can be associated with connective tissue diseases. A Steinbach syndrome can be associated with mitral valve prolapse. A kyphosis can be due to ankylosing spondylosis, which can produce aortic regurgitation. Then thoracic artery bruise or thrill may be seen in coarctation of the aorta. Intercostal artery thrills can be seen in coarctation of the aorta. So these are what you see in chest and abdomen. Then superior venical obstruction, you may see the dilated veins in the chest. Apart from this, the routine GPE, you will see pallor, cyanosis, and jaundice. Then, especially in cardiovascular system examination, two things which you have to see is any markers of rheumatic fever, like subcutaneous nodules, erythema marginatum, and any signs of infective endocarditis, anemia, petechial hemorrhages, osseous nodes, Janeway lesions, splinter hemorrhages. You have to look. Osseous nodes in the pulp of the fingers, Janeway lesions in the palms and soles, splinter hemorrhages under the nails. Then transverse earlobe crease and arcus senalis, markers of atherosclerosis, nicotine stain in the hand. So this is about general physical examination.